these are my disclosures. Why do we have to worry so much about these topics? Well, because you already heard in a previous presentation that obesity is increasing, female population is changing. It's not just obesity, although obesity is obviously a very big burden. It affects more women than men, and just being obese increases risks for pregnancy, particularly for the important health outcomes of pregnancy that we consider important. So you can see that I highlighted 3 times more GDM, 3 times and something more preeclampsia, and also prematurity. So being obese is an important risk factor for many, many of the adverse health outcomes of pregnancy. Sorry, I'm doing something wrong. Okay, here. And it's a problem affecting the whole world. It's not just the US where we saw that it's over 40%. I mean, you can see that apart from North America and Mexico, also the regions of Northern Africa and Middle East, but also, you know, in Italy we have a minor problem, but in France, for example, is more, and UK as well. So it's a problem all over the world. But it's not the only change that women are going through in these last years. So physical activity is significantly decreasing to less than 30%. And maternal age is obviously, we know very well that it's increasing, contributing to increases in gestational diabetes rate. Look at how much difference there is. Just concentrate for a second on the left and low part of the slides. And so the blue dots are women over 30 years old, and the red ones are below 30 years old, and you see the increases throughout the years, but for women older than 30, much higher, and for GDM. So because it's an inflammatory disease, and inflammation increases with age. It's well known. So then we can also see, however, in this slide that it's not just the single factors, because you can see, for example, let's look again at the lowest on the left part of the slide. You can see that in that case, it's representing income. So income, we know it's a significant risk factor. So lower incomes, which are the white columns, increases risk of gestational diabetes. But the increase is much higher in 2016 compared to 2006. So it means that there are also other factors that we maybe are not able so much to count, you know. So they may be maternal age, who is not in this slide, or diet, as we just heard, low sun exposure, high stress, little sleep. So a number of factors that in different countries may be different. It is a global change, so that we have really to expect that gestational diabetes is really the big burden in pregnancy. So is it possible to prevent it? Okay, diet and exercise are obviously something we always have to try to improve. We have to do it. There are studies that demonstrate that exercise reduces the risk by 30%, dietary intervention reduces the risk, and mixed interventions also reduces the risk. So this is important because in pregnancy we know we have to educate the woman because she will become a mother. She will educate her children. So this is an important effort we have to make to educate to diet and to exercise and to a good lifestyle. Because women stop smoking in pregnancy. They would not do it in other moments of their life. So it's an important educational moment. But then, of course, we also, today I have to talk also about some more supplementary and pharmacological interventions and show you what are the data that we have up to now. So you already heard about mio-inozytol. Mio-inozytol is a 6-carbon atom molecule. And in general, not just in pregnancy, it reduces insulin production, and therefore it has beneficial effects on endocrine and metabolic disorders, particularly also because it allows glucose to be taken up by the cell because it works on the glucose receptor on the surface of the cell. So it has been shown that in women, we already heard the data before, but it has been shown that it improves metabolic profile in women with PCOS, and therefore it has an impact on fertility, decreases in fertility. We already heard that. So what about prevention of gestational diabetes in pregnant women? This study investigated in 2013, 10 years ago, was very well published, Diabetes Care, the effect of mio-inozytol given from the beginning of pregnancy on incidence of GDM, and you can see that it was a randomized controlled trial, so the incidence was significantly decreased from 15% to 6% in that population, and that also birth weight and macrosomia had better outcomes. So the birth weight was lower and the macrosomia was practically zero. It was not big numbers, but there was significant results. Then the same group investigated also the same type of design of the study, but in women with obesity and overweight women. So two studies. The first on top is the results for women with obesity. Again, treatment started at the beginning of pregnancy, and you can see that there was a significant decrease from 33% in obese women that have high incidence of obviously of gestational diabetes. It was reduced to 14%, so less than half. And also in overweight women, there was a significant reduction in the rate of GDM from 11.6% to from 27 to 11%. So again, a reduction of more than 50%. And this is actually a meta-analysis of 6 randomized controlled trials that shows that mio-inozytol supplementation has significant effects on the incidence of GDM and also on the incidence of preterm delivery. But in this meta-analysis, there were no differences found for birth weight. Okay, so to summarize for mio-inozytol in prevention of GDM, it is effective in reducing GDM incidence in patients with a family history of diabetes type 2 and in women with overweight and obesity at the beginning of pregnancy. And dosage, you have to remember, the dosage has to be 4,000 milligrams every day. Okay, let's go to metformin. Metformin is a very well-known drug that acts on switching to catabolic pathways by suppressing gluconeogenesis and decreases lipogenesis. So it's different pathways than mio-inozytol. And it has systemic effects, so it has effects on, besides glycemia, also on gut microbiota, on decreasing inflammation, decreasing oxidative stress, and increases DNA repair. So it's very promising. Obviously, it's used already in diabetes type 2, so there have been some studies investigating metformin for the prevention of GDM. And you can see this study on the left was a randomized controlled trial published on New England Journal of Medicine in 2016 from the group of Nicolaides. And it did reduce only gestational weight gain. So it was not effective on GDM incidence. And by the way, you have, I put in red 3 grams per day because 3 grams per day is very high dosage, and it's probably also going to be not very well tolerated by a number of women. And in women with PCOS, instead, there were 3 randomized controlled trials and some other observational studies, but they didn't show reduction of GDM incidence, but no impact on other health outcomes. Sorry, they showed reduction of GDM, but no impact on other pregnancy outcomes. But the evidence is not really that high even in this population. Probiotics have been studied mainly in Finland up to now by the group of Kirsi Laitinen. And what they first showed was that when they randomized women with normal glycemia in the first trimester to take either controls or diet plus probiotics, in the group of diet plus probiotics, they had better glucose concentrations. They were lower throughout the 3 trimesters of pregnancy and overall better glucose tolerance. So therefore, they went on to a study in investigating prevention of diabetes in women that had risk factors. And that study showed that there was a significant reduction only in the group that had both diet and probiotics from approximately 35, 36% to 13%. So this is just one study showing this result, obviously very important. Probiotics, we know they act also on ameliorating glucose profile. And okay, let's go. I have to talk a lot about many things, so 3 minutes. Okay, management. The classical management of gestational diabetes mellitus, once we have a positive oral glucose tolerance test, you know, it's to provide nutritional therapy, self-blood glucose monitoring, and decide whether we need to use insulin to control maternal glycemias. Okay, so these therapies are known to reduce the worst health outcomes that we have with gestational diabetes, and particularly shoulder dystocia and all the things we all know, you know, also preeclampsia and preterm birth. Okay, what about treatment with metformin? I know it's very much utilized, but I want to just briefly show something about this. Okay, apparently, up to 16 randomized controlled trials on 2,000 and more women have shown that metformin has better effects than insulin on reducing maternal weight gain and also on reducing hypertension, pregnancy-induced hypertension. So it is apparently working better than insulin. What do the guidelines say? The guidelines, only UK has recommended metformin as first-line choice, and insulin only if metformin is not well tolerated. All the other guidelines actually say start with insulin and go to metformin only if there are some reasons that insulin is not easy to use for that woman, or you're in a context where it is better to use metformin. But also, what I want to tell you to conclude my presentation and go, I'm going fast, my last 2 slides, is metformin. Be careful, because metformin crosses the placenta, and so there are concerns that it may have some long-term effects on the baby, on the newborn. And why? Because it has effects on suppression of mitochondrial respiration, growth inhibition, and glucogenetic response. And now there are some data that came already out in Southeastern Asia and Australia that show that indeed babies that were born from randomized controlled trials where they used metformin compared to insulin, they had increases in their weights and fat mass at 7 to 9 years of age. And therefore, my conclusion, so this is my last slide, is that mainly I want to conclude about preventative interventions. So lifestyle interventions, really important, physical activity and or diet already before pregnancy in the preconception period. But also mio-inozytol has a role, may have a role that has been shown. And metformin instead, I wouldn't consider it as first-line choice, but it can be considered as a valid alternative to insulin for the treatment of EGM and for the prevention of PIH. Probiotics, I think, are, the evidence that I showed is not very high, so I think they need still to be studied. Thank you very much.